Hi everyone, and thank you for joining us today for our first webinar of this series. So today we will be joined by Dr. Alyce and Dr. Rachele, who are both trainees. Dr. Alyce is studying emergency medicine and Dr. Rachele is studying radiology, and we're very lucky to have them here today to talk to us about their careers.
Thank you.
So are we starting with Alyce first?
Yes. Do you want to give the brief bio for Alyce?
Yes, sorry about that. So Dr. Alyce is an emergency medicine advanced trainee. For our first session, she'll be giving us a brief introduction to emergency medicine. She also has a special interest in medical education and well-being. And Alyce also has a young daughter with a second child on the way. And she loves to read fantasy books, binge watch new TV shows, or just rewatching The Office, and playing board games with friends. So today she'll be covering what ED work actually entails, the pros and cons of working in emergency medicine, and how the ACM training program is structured.
Okay, thank you. We did do a little test of this before, but hopefully you were all seeing a PowerPoint there. Is that right?
Yep, that was good.
Fantastic. Excellent. So welcome. Thank you for having me here. If you can see me on the screen at all, then apologize. I've got a split screen, so occasionally I'll look this way to refer to my notes. So I'm going to talk a little bit about emergency medicine, what the work is like, what are the things that are the pros about it that I love, what are some of the things that are the cons that are a bit more of a challenge. And I'll briefly talk about, I guess, how to get onto the program, which basically is pretty easy. It's been changed recently, but it's still relatively easy, and also how the actual program is structured. As we were talking about before the recording started, a lot of this, I'll try and make that the briefest part of the talk, and I'm happy to receive lots of emails if anyone has more questions, because I think that's something that we never really get exposed to in med school and even in your junior doctor years, and half the time you just have to ask someone at work and they explain it to you. So it's nice to have a bit of an idea. This first picture is, I guess, what is probably one of the most important rooms in ED, which is the resuscitation bay. So when you all start filtering through doing placements and coming and working in ED a bit, this is something that as a junior doctor, you don't necessarily go in that often, although, you know, if you're keen and want to get in there, we're always happy. And this is where we get our sickest patients and try and resuscitate them and stabilize them. So a lot of gory, but really fun stuff happens in there. I guess, what is the work in ED? And I've made a little word cloud. I appreciate that sometimes there are two words squished together, but I didn't know how to make them all different sizes and not have them as one word. So first and foremost, I think in ED, our specialty is resuscitation. While that's not what we necessarily do all day, every day, that's the thing that we probably receive the most training in, is getting these really critically unwell, sick, sometimes, you know, very near death patients, and working hard to try and stabilize them, help them, improve them, maybe even completely fix them. Not always, but we try really hard. And then part of that resuscitation training is not just how to help those critically ill patients, but also how to have those really difficult discussions with the patients, with the family, trying to explain what's going on, and maybe even explaining that we weren't successful in resuscitating, which can be really challenging, but also really rewarding. But as you can see there's a huge list that is by no means exhaustive. There's a million things that aren't on there that also include what our work is. So ED, we're kind of a jack of all trades, really. We need to learn a little bit about all types of medicine, because we're the gateway keepers to the hospital system, but even to sometimes the outpatient system, or, you know, what the next treatments are. So we work similar to how GPs work, where they need to know a lot about everything and how to triage patients and send them in the right direction. So really our day can be very varied. So as some examples of what I've put in here, what could my day look like? Well, I might start off my day by having to procedurally sedate someone who's had a little foosh on their, you know, fallen outstretched hand. They've sustained a fracture to their wrist, and I might have to assess them, consent them, give them medications to sedate them so that we can pull that bone out to length and put a cast on, observe them to make sure there's no complications of the procedure, both the sedation and the reduction, and then make sure there's some outpatient follow-ups or follow-up properly. So do they need to stay in hospital for surgery? Do they need to go home and be seen in a fracture clinic? Do they have pain relief? All those kind of things. I might spend some time with this young female patient who's come in with some bleeding, vaginal bleeding, and I've got to decide, is she having a miscarriage or does she have an ectopic pregnancy? And I have to decide, what the most appropriate investigation is to try and figure that out. Do I need to go straight for surgery? Can I do a bedside ultrasound? Do I need a formal ultrasound? What blood tests do I do? What treatment do I give? I might have to perform CPR on a patient, on the man who presented with severe chest pain and then arrested while he was coming into hospital. And we might have to manage his airway and intubate him, try and figure out what exactly was the cause of his arrest. Do we need to give him medications to break up the clot? What do I need to talk to his family and explain what's happened and work out if he had any wishes, such as he didn't want to be resuscitated or not. So that can happen, and actually that happened, not that exact scenario, but happened at work yesterday, so it does happen. I might have to talk to the family of my elderly patient who's had a fall and sustained significant head trauma. I have to explain to them that not only may their loved one not survive, but also try and figure out what would they want for their end of life. I might also have to go and spend some time with this young child who's got a fever, and I've got to spend time trying to decide if this is a brewing sepsis or if it's just a simple ERTI. How sick are they? Can they go home, or do they need to stay in hospital? And if they're going home, what do I tell the family? What do I tell the parents about when they need to come back? So my day can involve all of these things happening in a single shift. And as you can see, it means that every day can be just completely different, can be really interesting. You never really know what's going to happen in your day, and there's always unique challenges, both from a medical point of view, from a procedures point of view, from that kind of empathic communication point of view. And in amongst all that, there's always managing, your own team and yourself. So I think ED is just this really variable but really fun workplace. So obviously it's a bit biased because I very much love ED and I love what I do every day. So I want to talk a bit about why I love it. I will talk about some of the negatives as well, because everything you go into has some negatives. So first, I find ED, I love the team. This is the staff Christmas photo from last year at the current ED I work at. And in that photo, there are consultants, there are nurses, there are admin officers, there are wardies, all getting together and having a really fun time together. And I actually had a really hard time deciding which photo to use because there were so many examples of photos of our team really getting together. We've done video challenges together. There's a lot of socializing happening between the different disciplines. I think that not all, but in a lot of areas of medicine, there's a bit of a divide, I guess, between specialties. There's maybe the doctors and the nurses, and you might get to know them and be friendly, but you're not necessarily hand in hand working as a team, giving each other advice. There has been so many times, particularly as a junior registrar on night shift, say, where I've gone to one of the nurses that's worked in ED for 20 years and said, what do you reckon? What should I do? Like, how do I manage this patient? I'm really good friends with a lot of people in the team. And I think that that's something that doesn't happen in all areas of medicine. And not only that, I think that the team in almost EDs I've worked at are really committed to excellence. The nurses really are phenomenal. They're hands-on. They do cannulas and drips. Half the time you're thinking, I probably need to go and give this patient this drug, and they've already pulled it out of the cupboard, ready for you to give it. They're really knowledgeable and really well trained. Same with the physiotherapy therapists. I think there's a lot of anticipating what needs to be done and working together to get the best outcome for the patient. And I just love that. It's a tiny picture, so I hope you guys can see it on your screen. But it's basically trying to show that every day is new and interesting. So as I talked about before, when I turn up to work each day, I never really know what I'm going to be in for. I have no idea what kind of patients are already in the department, who's coming in. Every day is unpredictable. Some days are obviously not as fun as other days. They don't have maybe as much, like I love hands-on stuff. Not all days are like that. But I think I also know that my personality type is the kind where if I had, say, a full day of appointments with patients and that was what my day was going to be like, and I kind of knew who was coming in, and I'd probably, I don't know, I probably find I'd get a bit bored of the work. I can't really handle sitting in one room for too long. I like moving around, being on my feet, having a bit of this, having a bit of that. And I think that that's one of the really fun things about ED. That's a picture there of a model doing a surgical cricothyrotomy. So basically, I think there's a great mix of knowledge and clinical reasoning, but also hands-on procedural work in ED. So you need to get these patients who've come in with, maybe some vague symptoms, maybe something more specific, but there's no real, you're the problem solvers, we're the detectives. We come in with really almost no information, maybe some information if they've seen their GP first and had a bit of workup. We've got to take our history, we've got to do our examination, we've got to decide what investigations we need to do, we've got to try and figure out what's going on. You need to have a reasonable knowledge base to try and triage these patients appropriately, decide what they need, start the initial treatment. So there's a good amount of knowledge and lots of study involved. But the flip side is also there's a lot of real fun hands-on stuff that we get to do. We reduce fractures, we do different types of specialized lines for sick patients, we do suturing, we do all kinds of fun procedures. So I think it's a really nice mix of having to use your brain and getting to use your hands, which most of medicine is, but for me, I find it's really very hands-on and on the front line in ED. It's a little photo of my little girl, Tilly. I think that the ED college, or in general, the ED college, most people agree, is really supportive. They're so fantastic for family planning, for leave, for bereavement leave. It's a very, very flexible training program where, it's very easy to work part-time. Some other programs, if you want to work half-time, you have to find someone else to share your half-time role with so that you're completing a whole person, So let's say you're on a medical team, you need two people to share the workload for that team. Whereas in ED, it's really easy to say, I'm going to work part-time, and the ED will just hire someone else who also wants to work part-time. And it's really easy to kind of be flexible with how much work you do and how little work you do. I have the one child and I'm expecting another, and both times I've let the ED I'm working in know that I'm pregnant, and there's been an absolute fantastic, excellent work until you want to work. Let us know if you ever want to go part-time. Let us know when you want to come back. It's all up to you. We don't mind at all, whatever you need, which is just amazing. And even things like when you are at work, this is for all the future or current mothers in the room, things like taking breaks for if you've got to express breast milk, or if you have an emergency where you need to go home to your child. There's never even the slightest bit of judgment. It is you've got to take care of yourself and your family first. The actual college itself, in terms of taking maternity leave or working part-time to accommodate family, but still completing your training, are really accommodating. So I think it's one of the most of medicine in general is moving towards that, but there are still some colleges, I think, that are a little bit stuck in the past and not as supportive to that, that need. So I think that that's something that's a really big bonus. And similarly, I put bereavement, including bereavement leave in there, because I know one of my colleagues, for example, is from the UK and her father unexpectedly passed away. The ED department we work in have not only completely supported her immediately flying back to the UK, but they're helping support her coming back, both financially, but also holding her job available, saying you come back when you need to come back, when you're able to come back, because obviously in this day and age, it's not easy just to jump on a plane from the UK to Australia. And there's just no real judgment at all. It's about you doing what you need to do for yourself and your personal life. So I think that that's something that's really amazing. This little mix of diagrams, we've got an echocardiogram there, we've got a chest drain, we've got an elderly patient, and we've got a intubation. I can't actually see on my screen. Intubation is basically me trying to show that in ED, it's really fantastic that you can carve out your subspecialty. So most specialties these days have some subspecialties involved. So you can choose to have a focus on education, or if you're in medicine, you might choose to go into like cardiology or this or this or this. There's different areas within the whole field. In ED, it's really, you can really pick your own. It is starting to become a college where, or a vocation where you do almost need to diversify to be an ED consultant and work full-time in ED can actually be quite exhausting and can lead to a lot of burnout. So it's actually pretty encouraged, and most people are moving towards working part-time, clinically seeing patients, but having this other special thing that they do. The examples I've had there is some people specialize in doing bedside ultrasound or bedside echocardiograms and become really well trained in that. And then in rolling out education for ultrasound in ED. Some people just love trauma. They do all the extra training in trauma. They work in trauma centers. They do lots of research in how to manage trauma. And they become really great, trauma proceduralists. Some people specialize in, say, what in Queensland or Metro South anyway is called Care Pact, or, becoming physicians that interface between the emergency department and hospitals with nursing homes and helping to medically manage some patients in nursing homes, to give training to the nurses and staff in nursing homes to try and keep these patients out of hospital and support their medical management and decision-making in the community. Some people go into, like, I have a very strong passion for education, so they go into simulation training. And I think it's just one of those areas where it's not necessarily set and rigid, and you can really go, you know what, I really want to learn more about this and do this and make that my specialty. And you can really carve it out yourself and decide what you want to do, which I'm not too sure about other training programs, but I know in ED, it's just something really versatile. You can say, I want to learn about education, so I don't even have to necessarily do more study. I'm just going to get a job that has a special skills role in education and train that up on my CV. So it's pretty cool how you can just make it work how you want to work. The other thing too is I put with the versatile training pathway. So like I said, you can pick elective terms. You can go, you know what, I really want to get better at palliative care. I'm going to go work in medicine and palliative care for 6 months so I can build that skill up. And you can really work in other areas. A lot of people do like obstetrics terms or pediatric terms, and you can kind of pick all those different areas to build up your skill set. So what makes it challenging? Because every job is a bit challenging. Shift work. So ED is obviously, emergency departments are open 24/7. They never close, so they need to be staffed 24/7, which can be really exhausting. The hardest bit, I think, is when you're a trainee like I am, because then you do runs where you do, 3, 4 or so, sometimes more than that, night shifts in a row, and it can be really tiring. As you become a consultant, at the moment, currently, there's less of that. You have nights where you're often rostered until midnight, and then you're on call until, say, 7 in the morning, where you don't necessarily need to be there, but you've got to be by your phone, ready to answer calls and ready to come back into the hospital if you need to. And depending on which hospital you work at, sometimes those on-call consultants actually sleep at the hospital so that they're right there if they're needed. So a good example of that is I've worked at Ipswich Hospital, where a lot of the doctors that work at Ipswich Hospital live in Brisbane and commute out to Ipswich. But if you're on call and you get the call saying a sick patient has just arrived, we need to intubate them, we need you here, you don't necessarily have the 30 or 40 minutes to drive to the hospital. So often those consultants stay there. There is potentially, there's a bit of a, there's lots of trainees and only so many consultant jobs, and a lot of the current consultant workforce are younger, they're not older, so there's probably not going to be any retirements happening soon. So there is potentially going to be complications coming up soon where there's more people finishing their training than there are jobs for them. There's some things in place like that. You do part-time ED, part-time education or something else. But there is potentially, there's been floated the idea that maybe one day consultants will do night shifts and actually have to stay and work in the hospital. But the college themselves are actually quite against that, because that de-skills registrars. Night shifts are when registrars are in charge and have to learn and make decisions, which really prepares you really well for becoming a consultant. So, and obviously no consultant wants to volunteer for night shifts. So potentially that won't happen, but it's maybe by the time some of the people listening to this talk go through the training program and ED doctors, it's potential. I also think that shift work in some ways for me is a pro, because let's say I'm meant to work on Friday, but I actually decide I want Friday off. I can always talk to my colleagues and swap shifts with someone else. It's really easy. As long as I swap with someone at the same level as me, it's not a problem. Whereas if I had, say, a ward round I had to do, or, a full day of appointments, all those appointments have to be moved, or I'm leaving the team down like down by one doctor if I decide to just call in sick that day or can't say I can't come in that day. So in some ways it makes it really easy. And I've actually had a lot of female ED doctors who've got families who say that they love ED because it gives them so much flexibility. They can very easily say, I want this time off to go to my kids', you know, sports carnival or whatever, and I can just swap my shift and go to it. So it's got a lot of benefits to it, but it is also can be very tiring and hard work, especially because ED is a specialty where you don't spend a lot of time sitting around. You're usually on your feet, you're usually running around, you're usually hands-on, bending down, kneeling, doing procedures. So it can also be physically tiring. Emergency departments are becoming increasingly busy and under higher pressure. So we're having more and more, the healthcare system in general, there's a bit of a crisis that's been coming for about maybe 10 or 20 years and is probably going to get worse before it gets better, where a lot of community services are being defunded. So people are finding it harder to access care in the community. So they come to the emergency department. Like, you know, your GP's booked out for 3-4 weeks, or, you know, they can no longer rebate every appointment because Medicare is not going to rebate them. So they're actually taking a loss if they don't charge, all those kind of things. So people come to the ED, and then we're having issues where there's not enough beds on the wards. So often patients are staying in ED for 12, 24 hours waiting for a bed on the ward. Meanwhile, patients keep coming in the door. We're seeing them in corridors. They're on the ramp, on the ambulance, you know, stretchers, just what we call ramped, where they're waiting for a bed. Sometimes we see them on the ramp and they go to the ward, or we can almost discharge them for the ramp because we've seen them and sorted them out, and it's becoming a bit of an issue. And that puts a lot of stress on the ED doctors, particularly when either as a consultant or a registrar, you're in charge. You've got to make the decisions. And when there's already no beds in the department, an ambulance bay full of patients waiting to be seen, and the waiting room's getting increasingly busy, it can be quite stressful, because when you've got 40 patients waiting to be seen and only 3 doctors or 4 doctors at night seeing them, if there's a sick patient hiding in amongst those that you haven't had the chance to recognize because the nurses are too swamped to do vital signs on absolutely everyone, and that patient gets sick and dies, which has happened, I mean, that's kind of traumatizing as the doctor in charge, that somehow that slipped through the cracks, even though it's a Swiss cheese model that's not on you, it's on the whole system, but it can be really stressful. So it's a recognized problem. There's been numerous statements by the college. Even the actual, you know, higher up authorities are recognizing that this isn't necessarily an ED problem. It's a problem within the whole system, that an ED is where the suffering happens, and they're trying to fix it. So hopefully, who knows, maybe by the time you all finish, it'll be a lot better, but it can be quite stressful. You know nothing. So I think one of the things that can be really disheartening as an emergency trainee or as a resident working in the emergency department is we're often a jack of all trades, as I mentioned before, and a master of none, I'll say. Like I said, we do tend to get lots of training in resuscitation, and we tend to be really good at that. But everything else, we know a fair bit. You know, our textbooks are still this big. We still need to learn a lot about everything. And generally speaking, especially when you reach the end of your training, you are actually really knowledgeable, but you don't necessarily know as much about how to manage this specific condition as the specialty that devote all of their career to managing that condition. And sometimes when you're trying to refer a patient to an inpatient team, or when you're trying to, you know, call the admitting registrar for advice or whatever it is, you know, you're the person bringing them their work, making their day harder because you're giving them work to do. And to them, they might think, well, this is, or maybe, you know, for example, some surgical specialties are on call for 24 hours and they could be exhausted and had a million calls already. And you're just making their day harder. And they might just think, you're an idiot. How do you not know how to treat this condition? And sometimes they say that. Sometimes they actually verbalize that to you. And I've had more than once a resident try and refer a patient and end up in tears. And it's really mean. It's not nice at all. And it's not acceptable. Funnily enough, it seems to happen more with the I guess, inexperienced inpatient registrars. And as those registrars become more senior, they actually tend to be a lot more like, yeah, that's fine, I'll come see the patient. They might not need to come into hospital, but I'll sort them out. I think they tend to, I guess, be a bit more understanding, but it can be really disheartening. So I would, number one, a lot of it's about your own well-being and trying to support your team around you, you know, trying to, you know, convince people it's not their fault if they've been spoken to meanly. One of the best bits of advice I got when I was an intern, about to start my internship, was if anyone ever speaks to you meanly or harshly, even if you've made the most catastrophic mistake, it's not a reflection of you, it's a reflection of that person's ability to maintain or manage their own emotions. There's never a reason for someone to be rude to you. So I think trying to keep that in mind, but also if you end up working in a different specialty and ED calls you and internally you're rolling your eyes and groaning and thinking, oh my God, these people are incompetent, try and be nice, try and remember that we've called you this one time, but there's probably 20 other patients we could have called you about, but we actually sorted out and discharged or sorted them out without needing to bother you. And when we call you, we're really asking for advice. We're asking for help. We're reaching out a hand saying, can you give us a bit of help? And try and be kind, basically, be kind. And the other thing I've added in here is, I guess that there are some specific challenging scenarios that happen in ED that can happen anywhere in the hospital system or in healthcare in general in the community, but that can kind of be hard in ED when it's a stressful environment. Often when a patient comes into ED, it's their worst day. They think this is the sickest I've ever been, which it may be the sickest they've ever been, but sometimes, you know, our perspective is different because yes, you've got your horrible tonsillitis and you feel so sick with it, but I've actually got a person dying next door. So my mind is on a different level than yours is. But we do get it increasingly, there is workplace violence. There are patients and family members who can be verbally or physically aggressive. You know, that might be because they're just frustrated, or it might be because they're intoxicated or something like that. But that can be challenging. We end up becoming very good friends in ED with the security that work in the hospital, but also with the medications we use to urgently sedate people. We get to know those very well. But sometimes, you know, you always want to try and start with verbal de-escalation, and that's a skill set that I think you've got to build up pretty quickly, especially when you're a trainee or a consultant. And then there's also just other challenging situations, like a lot of those really difficult conversations you've got to have with people to try and explain what their diagnosis is or what their prognosis is, or even, like I said, to sadly say to a loved one, you came in with your partner or whomever, you know, 15 minutes ago and they've died. Like there's nothing we could do. So, and again, that's a conversation I had yesterday. So it's really hard, but I think in some ways can be really rewarding when you manage to do it well, when you manage to, you know, verbally de-escalate and calm down your dementia patient who was becoming increasingly stressed and anxious about being in this unfamiliar environment, that you've made them a cup of tea and asked about their grandkids and you've calmed them down. It can be really rewarding to do that. So it's challenging, but I think if you've got the right mindset, it can be rewarding. And there's probably other challenges that other people have, but those are the ones that I thought of. So just quickly, I'll try and, have I gone really over? Am I okay time-wise?
You've got a bit over, Alyce. I think it's been very interesting though. So no, don't worry about it at all. It's been amazing.
Okay, good. I'll try and be really quick for this bit. I won't go into this in too much detail. To join the training program is really easy. It was easier when I joined, because I knew they were changing it. So I slipped in a bit early, but it's essentially, I think it's your resume. You need 3 signatures from ED consultants and including one from whoever the director is of your emergency department, which generally speaking, they will probably do for anyone. They're really, basically, I don't think I've ever heard of an ED consultant refusing to endorse someone to join the program, because we're always willing to have everyone. We realize there are steps in place that if someone's really not suitable to ED, they probably won't be able to progress the whole way through, but we give everyone the opportunity. And I think you submit that. I think that's about it. There was talk about introducing an interview, but it hasn't happened yet. I'm not sure if it will happen. So it's really easy to join. The training program itself is basically, you have to do 12 months of ED, and that's early phase of training, or at least 6 months of ED and 6 months of something else that can be ED or cannot be, and that's early phase. Provisional phase. Then there's basically sitting your primary exam, which is a written exam, and a Viva, so in person or via Zoom these days, exam. Once you've passed those, you're a late phase or advanced phase trainee, which is early and late. So late advanced trainee, 12 months of ED, and now you're late phase, and then it's 18 months, and you need to do some time in like ICU anesthetics, and you might do some time in other specialties like peds or you know, simulation jobs, or you might work as a gen med reg for a while just to build up your skill set. But once you've completed your training time, you do another final set of exams, and then you're through. And what on the job, there are some work-based place assessments that are usually quite relaxed, and they're mostly discussions about patients or doing procedures. But it's usually, it's a, you know, relatively straightforward program to follow. I don't know if you want to go to questions from me now, or if we want to just go to Rachel and do questions to me later. I have included there for you my email address, and I'm very happy for anyone to email me with questions they specifically have that they don't want to ask in the group chat here, or even any advice or anything like that.
Just checking the chat. I think there's a few thank yous there, Alyce. So yeah, maybe if anyone does have any questions, absolutely feel free to type them in there, send them to Alyce, and also you can send them to the sort of Med Careers website as well, and I can sort of help get in touch with Alyce that way. Brilliant.
Well,
great. All right, back to you, Emily.
Yes, so thank you, Alyce. That was really interesting. Yeah, so if anyone has any questions, they can just pop it in the chat or email Alyce. So next we have Rachel, who is a radiology trainee. She also has an interest in medical education and wellbeing. And Rachel has 6 children between the ages of 2 and 16, is learning the piano, enjoys triathlon, and she trains whenever she can. So in a talk, Rachel will cover what radiology work entails, the pros and cons of working in radiology, and how to increase your chances of getting into the program. All yours, Rachel. So it looks like there was a question in the chat actually. When you say job market after training is looking scarce, can you elaborate? Are there large groups of trained doctors without, are there large groups of trained doctors without jobs?
It's a little bit of a problem at the moment, but it's projected to become more of a problem. So I'm specifically talking about emergency training, because I couldn't comment on other specialties. It's projected with the current age kind of demographic of consultants, a lot of them are younger, that they're probably not going to be retiring in the next, 10 or 20 years, which means every year more people are completing their final exams and they're finishing their training time and they're ready to be consultants. It can be competitive to get a job at the moment, although most of them, like a lot of people, like I said, do 0.5, that's half-time work, and they might work half-time at this hospital and half-time at this hospital. I think it's probably going to become more and more of an issue in like 10, 20, 30 years when there's just more people graduating and not as many jobs available. There are other things that though the healthcare system's doing, like there are new hospitals being built and things like that. So I think there'll always be jobs. It's just going to be that you might find that if you're anticipating just to finish, work in hospital, full-time ED, have a job straight away, you might find that a bit challenging. You're probably going to have to spend some time working, a couple of shifts a week here, a couple of shifts a week here, and then over time eventually get promoted to be full-time, permanent in one job. And potentially a lot of other specialties are like that as well.
Brilliant. We also have a second question from Jack. It's a pretty long question. Could I ask if you could just type a response in the chat, Alyce?
Yeah, of course. Yeah.
Can just
absolutely.
Excellent. Thanks, Emily. So my talk is about radiology and your brilliant radiology career, potentially. So I think when it comes to any career whatsoever, and as some of you have met me in my context as a career sort of counsellor at UQ, one of the most important questions is to why you might want to pursue a particular avenue, and whether it's radiology or ED or dermatology or medical education, the why is a really important question. And you may actually not arrive at that why for a very long time. Sometimes people are a bit afraid about the why, and that, oh, actually, why do I want to do a job? My most important thing is I want to be employable, or I want to earn money, or I want to have a family life, or I want to travel. So the influences for your job might be a really important thing to consider when you're trying to find that trainee, the job that will answer all of your dreams in terms of your medical career. Like Alyce was saying, that ED training there's all sorts of amazing things about ED training, but at the other end it could be a little bit of a time before you get a job, and that may be something that is not a problem. It might be something that's really important to you. So figuring out those sorts of things can be a really useful way to help navigate your own path. Some of the things with radiology, I guess, sort of jumping straight into that end, is that it actually does have excellent current and future job options. There's only more and more opportunities within radiology because we're developing more and faster scanning techniques, and we're doing more and more things within a radiology sphere that they used to do in things like surgery. So it's a really expanding sort of area that, to be honest with you, I knew nothing about really during medical school, and in terms of what you did and why you did it. In terms of where you want to work, one of my directors recently just said to me, you actually just pick. You can certainly say, I actually just want to work on a Monday afternoon between 1 and 6, or, literally there is that sort of diversity. But it also depends on interest as well. So where are you interested in? So with the radiology perspective, everyone wants us. So one of the most important things in ED is the abdominal CT scan, which is a constant conversation that we have. And, is there a surgical problem? Is it a medical problem? Radiology helps define where a patient might go to, whether they need admitting. And that's sort of at the pointy end of the business. At the other end, it may be that you're really interested in cancer prevention and sort of life prolongation and quality of life for a public patient. So you might be really interested in looking at things like breast screen and trying to sort of find that little tiny little dot that might actually mean someone's got a cancer that's treatable versus something that's gone too far. So there's a massive range of where you can work and where you can specialize, or you can stay as general as you like and see every single thing that comes through the door of a local ED practice, ED or GP practice. The other thing with radiology is that you really are generally in complete charge of your daily existence. It's shift work, which is something that I wasn't really anticipating. In a hospital training perspective, it is. But at the other end, you can, depending on who you work for and where you choose to work, you can really be in complete charge of when you work and why you work. It's also, I have actually found it to be really difficult. I have found turning those grey dots of an MRI into something that is meaningful and a diagnostic solution is actually been a difficult challenge. So the process of learning radiology and the anatomy and everything underneath it is a challenge, and one I like studying. I like challenges like that. So I've actually enjoyed it. So if you get to the point that you think, yeah, radiology is for me, you want to get a bit of experience within something before you go down that path. And I guess things like surgery, GP, ED, medicine choices, a lot of those were given during medical school, but it's not always that common that you will get exposure to radiology, except for the fact that you get exposed to it every single day in a hospital environment. So it may just be that, oh, look, that X-ray shows a broken bush, from a broken radius and older that needs to be relocated, but at the same time, that's radiology. So there's a radiologist on the other end of that looking at that, and what the radiologist will see that the ED team may not see because it's not their job is that underneath that bush is actually a bone tumor. And that happens, you have a pathological fracture, which is not always immediately obvious to the non-radiology ED trainee. So those are the sorts of things that the radiology trainee might pick up that the sort of other specialties might miss. Or you've got someone who's having a surgery for a cervical spine and the bottom part of the brain is there, and the spinal surgeon sees that there's a C2-3 fracture that needs fixing, and the radiologist sees the brain tumor or whatever it is that needs to else be picked up on. So you see radiology every day. There is the opportunity now, and we've had a lot more students come through from UQ in fourth year as an elective, and regardless of where you want to do it, it's a fabulous elective because you learn how to read chest x-rays, which is one of the most important things you'll do anywhere. So in ED, in medicine, pediatrics, even in surgery, the chest x-ray is ubiquitous, and being able to see a left upper lobe collapse versus a right lower lobe pneumonia or any other sort of really big signs is actually really important, and actually not something I found was really well taught. You get the occasional tutorial. Certainly in places like ICU and ED, there is a bit more tutorials on things like reading basic x-rays, but it's difficult, and getting that extra knowledge is really good. In some hospitals, there are resident rotations through radiology. So I know the Royal offers one. The PA is talking about one. That's where I'm training at the moment, but we don't have one yet. So it can be difficult to get formal training experience in radiology once you're in your working years. But as I said, every rotation has exposure to radiology. If you're keen on radiology and you're thinking about how else can I put myself in a position, publications and presentations always help. And that's pretty much, and again, this is where most other specialty training programs become competitive. So there are processes whereby you need to tick a whole bunch of boxes in order to be considered eligible to sit for an interview, for example. So one of the things that radiology loves is something you could all do tomorrow, and that's a Radiopedia edit. So Radiopedia is one of the biggest and most important websites we have in radiology. You used it in medicine, you'll use it in ED. It's a really great way of explaining some of the basic signs that you'll see on various radiology medium. And actually it's an open editing. So it's not like you can just write something and say, make up anatomy and stick it on the web for everyone to see. It's edited by their overseeing editors, but it's a good way of getting something on your publication, or on your CV, if you like, to make yourself more interesting to the radiology team for interview. Now, the other thing is physics. So this is sometimes physics and anatomy are the two massive things in radiology that you need to know. I passed the surgical primary and the radiology primary exam, and I can tell you that the anatomy and the radiology was much harder. You need to know everything in detail, so you need to enjoy anatomy, but also physics. So physics is like a barrier, and as that sort of photo indicates, MR physics is sort of next level, and you sort of get it and then you forget it, and then you sort of integrate what you need to know as part of your everyday existence as a radiologist once you've passed that exam. But that physics Westmead course is something that they like to see on your CV, and anyone can sign up to do that at any time. You just get given access to their lectures that you can look through, and whether you choose to do the exam afterwards is up to you. And then the final and most easy thing is every hospital that you'll work at will always have a radiology department, and go in and have a chat. Very rarely would they say to you, go away. They're always like any specialty. They love to hear from you if you're interested in their specialty, because everyone who has done any specialization, or generalists like GPs, they've lived and breathed this job for years. And it's always exciting when someone who is interested comes and wants to talk to you. Sometimes it can ignite your own interest again if you've had a difficult day or whatever's happening. When you see things through the lens of someone who is excited to be there and wants to know more, it can give you a bit of joy. So not everyone, though, I guess, having said that. So when you find the right person, so most hospitals will have a director of training. Most of them will have like an executive assistant to that director of training. So if you don't feel confident just sort of rocking up with your CT request or CTPA request form from ED, probably don't speak to them at that point. But you can have a chat to them and say, look, I'm really interested in radiology. Can I come in and go to a tute? They'll often allow you to join in their tutorials, and or just sort of leave you a little bit of a look out and leg up. That's actually how I got here, is through not through desiring to do radiology, to be honest, but because I'd spoken to my local ED radiologist so much. He said, Rachel, what are you doing? Come join us. And here I am. So that's literally how it happened. And so being open to different jobs is also something to be aware of. I think it can be really easy to pigeonhole yourself. You're like, oh, I want to do this. This is what I'm going to do. But sometimes life doesn't work that way, and you want to be open to an opportunity that may not be something you've thought of before. And coming to that, when you start radiology training is really, really variable. So some people will start, and in first year uni, they'll go, yep, this is what I want to do. And they'll end up in that pathway, which is great. Other people in first year uni have no idea. And other people are thinking, oh, maybe, probably, not sure. So a lot of people in radiology I'm PGY 7 and still only a second year. And there are actually PGY 7, 8s, 9s that have started in their first year with radiology. So it's a career that, but there's also people that are PGY 3. So it's a career that spans different or spikes different interests for different people at different times. You can start applying in JHO year, but there is no prejudice to you if you've done years of other things, because they actually love that you've got exposure to other areas, because that clinical experience that you've had elsewhere can really help you turn a flat picture into a patient with a problem and then a solution. In terms of when you want to apply and how you apply, some people take many interviews to get on, some people don't get an interview to start with and then they work their way up through the interviews. There's no limit to how many times you can apply. There are changes, and this again is good advice for every college. They'll often change the selection criteria, and they will go through massive revisits of the whole training program, which is what radiology is doing at the moment. So from next year, the entire thing is going to be different. So that can be a little bit scary when you're in the middle of it. But it just means that you need to check in with anything that you want to do, check in regularly with the selection criteria and just see what it is that you're expected to do if you're going to apply in that sort of year or the next year. And the other thing with the radiology training program is actually advertised through Seek. So you don't go through the RMO campaign, even though you have to fill it in. Once you become sort of on that idea of radiology training, you sort of exit a little bit through the generalized process and start looking at going out to Seek and things. I'm not quite sure why, it's just the way that that's evolved. When it comes to sort of inside tips with radiology, if you do get to the point with the interview, at the moment, the process is a bit scary. You have little old you sitting in the room, and there's like 12 people sitting around you, and they kind of fire questions at you. So all of you will have done an interview. There has been a situation before we did interviews that sometimes the first interview was this, which is pretty intense. But you've had practice of MMIs, and I think from an interviewing perspective, if you're interested and excited and you sort of know why you want to do radiology, it's a question that recurs. Pretty much every sort of interview will say, look, why do you want to do this job? And if you can answer that honestly and with passion, then that's a really good way of saying, yep, you're ready for radiology training, because they don't actually expect you to know anything about radiology. I promise you. At my interview, they showed me a picture of a cecal volvulus, which everyone should know, but I'd been doing ortho. I didn't know what a cecal volvulus was. So I was like, I think there's an obstruction because there's this really big dilated. So they don't expect you to be radiologists when you start. They just want to know that you're interested in radiology and that you're a part of a team. The way Queensland Radiology works is we have 4 hubs. One's at the PA, one's at the Royal, one's at the Sunny Coast, and one's at the Gold Coast. And they'll ask you to preference those. Every single hub works really differently. So the PA, for example, we all do night shifts. It's quite an intense roster and extremely busy hospital, but we actually get farmed out. So I'm at the Gold Coast next term. I've been at the kids last term, and we work in sort of 4 terms a year. And so those could be at 4 different hospitals. So you get a lot of exposure to different areas, which can sometimes be tricky. Other areas tend to keep their sort of trainees a little bit closer to home. So every hub works a little bit differently, and they actually really enjoy you coming up and speaking to them. So you can arrange to meet the director of training at each hub in your process as to whether you want to do radiology or not. And then you can ask them all of those questions. They're generally really keen to hear what your questions are and happy to help you sort of figure out what suits you the best. And really that's sort of radiology in a nutshell. I think that from a career perspective, you may or may not know much about it, but it is certainly an evolving career. It's something that has eminent employability. AI is something that people often get a bit concerned about. Is it going to take our jobs? And the answer to that is an emphatic no. It's going to make your job better. The thing about AI is it can find a pulmonary nodule way better than we can if it's of the right size, and the machine can learn to do the parts of your job that may actually become a bit boring. But at this stage, could be wrong in 50 years. It could all change and the robots could do everything. But at this stage, it's only going to enhance our career. And I think radiology is an expanding specialty. So it's an exciting area for me to be in at the moment. So that said, I'm just going to have a quick look at the chat. But if anyone has any questions, please raise them now or send me an email later.
I just want to add, I did put in the group chat, but I did an elective rotation in radiology as a med student. I just organised it privately through Queensland X-ray, through someone I knew who worked there, but I'm sure you could probably just, email them and they'd be able to organise something for you. And I really highly recommend it. It became probably one of the most valuable rotations I did as a med student. I learned so much. Most of my day was looking at CT scans, that the radiologist had amassed a whole bunch of interesting CT scans. Not only did I learn so much about reading CT scans, but I also learned a lot about a whole host of other conditions, because I saw something, read the report and found this was a diagnosis, and then learned about that diagnosis. So I think it's a really great specialty to do in general.
Excellent. Same to ED too. Emily, over to you.
Yes, those are great presentations, actually. I found them really interesting personally as well. So if anyone has any questions, by all means, email Rachel or Alyce, or put a question in the chat while we're still here. And otherwise, thank you for coming today. The recording will be made available. Where will it be, Rachel?
So we'll put it up on the Medical Careers website. In addition, we're going to try and put it up in a few different places, maybe Blackboard. We're just investigating that at the moment. We're hoping that this will turn into a sort of a proper series with a whole bunch of different doctors coming in and talking to you, and also a podcast. So always check back in with that Building Your Medical Career website through the medical program landing page, and everything that we do will definitely be at least in that location. And if there are other places that we can put it that you think might be interesting, then let us know as well. So the UQMS pages or the Pre-Med Society pages, we're really happy to make this available, because this is a resource that we hope you guys can come back to and draw from, because I think hearing from people like Alyce and stuff, so people who are doing the job and keen and love it and can sort of give you a bit of inspiration, we want this to keep to be there for you. So at least the Building Your Medical Careers landing page, and hopefully elsewhere as well, will keep you up to date through Blackboard.
Brilliant. Okay, and yeah, it looks like there are some questions in the chat, but I think you.
Yes. Yep.
Yes.
For the interventional, yeah. So interventional is a fellowship post radiology. So they're the guys that get up at night and sort of reverse strokes. I saw the most amazing one the other day in ED, this massive MCA stroke, which is sort of one of the big arterial supplies to your brain. The person had a very dense hemiplegia. And so within about an hour, so they came in, had good clinical signs. The ED team alerted neurology. We came in and had a look at the scans, spoke to the interventional team on the table. And then about 2 hours later, I looked at their subtraction angiogram, so which is what the interventional guys do. And there was this supply to their whole brain again. And those are the sorts of things that can sometimes give you tingles. And that's the sort of stuff that interventional guys do. So yeah, that's a post radiology training fellowship.
Right, and are there extra barriers or exams to do before you get it?
They've, like anything, they're often making more and more barriers in exams. So they've just introduced an exam for interventional radiology. So yeah, you do your primary exam in radiology, then you do your exit exam for radiology, then you do your fellowship for interventional, and yes, there's an exam at the end of the fellowship.
Okay, we've also got a question about radiology. Does the type of publication matter?
No, they're not like, so some surgical colleges, for example, I know ortho, you need to have a minimum impact factor of 1. Plastics lets you know that there's about 4 journals that you can publish in. Everything changes on a yearly basis. So even what I just said may be out of date. Radiology don't tend to mind so much. It's more, have you shown that you've done some research and been a participant? So you could have presented a poster somewhere. I think, even just things like our local UQ student meeting, which DI arranges every year for research, that will be acceptable too. It shows that you've done something, you've sort of taken a project, you've turned it into something and presented it somewhere. That's the sort of stuff that they want to see. So the level and the sort of where it's done is not always important when it comes to your application.
Yep, and we have another question. So in comparison to ED, are consultant jobs also becoming harder to find?
No, definitely not at this stage. And it all depends what you want to do. I literally had a discussion with a recent director of training who said you can figure out what you want to do and then go work there. Places like the PA are always looking for new consultants. There's always more scanning to be done. Often it's from a public perspective, it can be just the money. Have they got enough money to create a new consultant position? But generally speaking, if you want a job in a certain place, you'll probably get it if you've enjoyed yourself at that location and you're the right fit. Consultant jobs in radiology are definitely not hard to come by at the moment anyway, and that shouldn't change in the next 10, 20, 30 years.
Well, I'd add that, and Rachele could probably say way more about this, but definitely I think that there's a bit of a movement clinically. If you have a type of radiology or a type of imaging that can be done to confirm a diagnosis or something, that in itself costs money, but it might save a patient from an inpatient stay or a surgery that they don't necessarily need. There's a bit of a push to do more imaging, not less, where I guess relying a little bit less on our clinical acumen, because it can be hard from a medical legal point of view to defend, sending someone home without imaging when you assume this is okay, when it's not it's a grey area at the moment. We're still leaning a bit towards clinical acumen, but there's definitely a bit of a push from some specialties to get imaging done. So I would argue that potentially there's going to be even more role for radiology in the future, not less.
Brilliant.
Yeah. So I guess we're good to wrap up for this webinar then, if there are no more questions.
That's great. Thank you so much, everyone.
Thanks for having me.
Thanks, Emily.
Thank you, Alyce. No worries, Rachel. Thanks for having me as well.
Bye.